Good morning, everybody. Thank you for joining us today. This session is Advances in GI Cancer and Chemo Prevention, Lifestyle, Diets, and Drugs. I'm Jenny Marat, and I have the honor of co-moderating the session with Dr. AJ Bansal. So this is Dr. Mingyang Song, who's coming to us from Mass Gen at Harvard Medical School, and he's going to present change in lifestyle after colonoscopy screening in relation to incidence of colorectal cancer and major chronic diseases in 3 U.S. population-based cohorts.
Good morning. Good morning. So first, I want to thank AGA for choosing our abstract for presentation, and also want to thank the moderators for introducing our study. So today I'm presenting on behalf of my postdoc, Dr. Marcus Nielsen, who unfortunately couldn't join the conference. I have no financial relationship to disclose. So to this audience, I guess I don't need to say much about colon cancer, which is a leading cause of cancer-related death in both this country and also across the world. And the colon cancer has a very nice, very well-established natural history. The majority of colon cancer develops through this adenoma-carcinoma pathway. And because of the very well recognized precursor lesions for colon cancer, colonoscopy screening has been shown to be very effective to not only detect cancer at an early stage, but also to prevent carcinogenesis by removing precursors. However, we know colonoscopy screening is not perfect. So individuals can still develop CRC after colonoscopy. So this is a so-called post-colonoscopy CRC, which has become an increasingly challenging endpoint to address. And we know that colonoscopy can only prevent CRC. There can be other chronic diseases that also affect the individuals. On the other hand, diet and lifestyle has been shown to play a critical role in the development of colon cancer. And also, a lot of the dietary lifestyle factors also influence other chronic disease outcomes. So this leads to the question how we can better integrate the two key pillars for colon cancer prevention. The one is healthy lifestyle, the other is screening. And one approach to do that would be to consider colonoscopy screening as a teachable moment for lifestyle change. So this can help optimize the benefit of colonoscopy screening by taking advantage of the clinical, the healthcare encounters. So this is a study that we did a few years ago, led by my former postdoc, Dr. Kai Wang. So in this study, we looked at how much percentage of colon cancer that can be potentially prevented by combination of healthy lifestyle and screening. And for healthy lifestyle, we considered 5 major factors, including no smoking, normal body weight, physical activity, no or moderate alcohol drinking, and healthy diet. And we classified individuals to the healthy group and compared the CRC incidence and the mortality to the unhealthy group. As you can see here in the green bar, about 34% of CRC incidence can be potentially prevented if all individuals in the population adhere to the healthy lifestyle recommendations. And for CRC mortality, the percentage is a little bit lower, 23%, but still sizable. And for screening, we can see that colonoscopy screening is associated with about 30% preventability of colon cancer. Again, if everyone in the population adopts screening. And we further looked at the combination of the two factors. We can see the percentage increased to 55 to 60%. So this indicates that both diet, lifestyle, and screening can independently reduce CRC risk. So for this study, we want to address do lifestyle changes after colonoscopy screening influence CRC and major chronic disease risk? So addressing this question can help us understand whether colonoscopy screening can be a truly teachable moment for lifestyle modification to optimize the benefit of screening encounters. To address this question, we leveraged the data from 3 ongoing prospective cohort studies, including the Nurses' Health Study, Nurses' Health Study 2, and Health Professional Follow-up Study. The Nurses' Health Study was established in 1976, including over 120,000 female nurses aged 30 to 55 years old. And the Nurses' Health Study 2 enrolled over 100,000 female nurses aged 25 to 42 years old in 1989, so a younger female cohort. And the Health Professional Follow-up Study is a parallel male cohort that enrolled over 50,000 male health professionals aged 40 to 75 years old in 1986. In all 3 cohorts, we have been collecting very detailed screening diet lifestyle information every 2 to 4 years. And for this study, the detailed screening and lifestyle information was first collected in 1988 in the nurses, 1991 in Nurses' Health Study 2, Nurses' Health Study 2, and then 1988 in Health Professional Follow-up Study. So these are considered as a baseline for the current analysis. And we followed these participants until 2018 or 2019 in all 3 cohorts. So in total, we have over 100,000 individuals who have received a colonoscopy screening and also provided very detailed risk factor information. And we have up to 30 years of follow-up. And during the follow-up, we have documented 534 cases of instant CRC. So the study design, when a participant reported receiving a colonoscopy screening on a questionnaire, we extracted their lifestyle information from the prior questionnaire. And this questionnaire has been done every 2 years. So this would be 2 years before the screening. And we then extracted the questionnaire 2 years after screening. So we would have the pre and post screening lifestyle. And then we calculated the lifestyle change after colonoscopy screening. And then we updated this information by using the repeated assessment in the subsequent questionnaires. For the lifestyle definition, we again considered these 5 major lifestyle factors. And each of the factors was scored either 0 or 1. So when a participant met the low-risk criteria, met the healthy lifestyle definition, they received a score of 1. And then we sum all the 5 factors, and therefore the overall score would range from 0 to 5. And for healthy diet, we assessed the diet based on the World Cancer Research Fund and the American Institute for Cancer Research dietary recommendations for colon cancer prevention. So it considers the following dietary factors, and if individuals meet at least 3 of the following, like healthy dietary recommendations, they would receive a score of 1. So that include red meat, very low consumption of red meat, and even more limited consumption of processed meat, and high dietary fiber intake, dairy consumption, whole grain consumption, and calcium. These are the dietary factors that have been shown to be associated with colon cancer risk with convincing evidence. The study outcomes include CRC incidence and incidence of major chronic diseases, including any cancer, CVD, and type 2 diabetes. And we used the Cox proportional regression stratified by cohort, age, and calendar time, and by further adjusting for demographic and other lifestyle factors. And we also adjusted for pre-screening lifestyle score, so that we can capture the effect, the impact of the change on the outcomes. So the average age of study participants at screening was 61 years old. Remember, this is a historical cohort, and so the starting age of screening can be a little bit older than the current recommendations. And when we look at the distribution of person years according to the change in healthy lifestyle score, we can say that half of the person years received the score 0. That means the participants didn't really change their diet or lifestyle after screening. And 22% increased their healthy lifestyle score by 1. That means they made some improvement in their diet and lifestyle. And only 5% increased their healthy lifestyle score by at least 2. And similar percentages was also found, like this would indicate 19% of participants adopted a less healthy lifestyle after screening, and 4% adopted an even unhealthy lifestyle after screening. And this is a primary results. The x-axis shows the 5 categories of the change in healthy lifestyle score. And the y-axis shows the multivariable adjusted height ratio. And we use individuals who didn't really change their diet or lifestyle as a reference group. We can say that compared to the reference group, individuals who improved their lifestyle showed a reduction in their colon cancer incidence, whereas individuals who adopted an unhealthy lifestyle showed a higher risk of developing CRC. And we observed a statistically significant trend. And this is a result for instance of major chronic diseases. We can see we observed a similar trend, although the confidence interval is much narrower, mainly because we have much more number of cases for major chronic diseases compared to CRC. And when we look at the proximal and distal rectal cancer separately, we can see that the results are largely similar. Healthy lifestyle is associated with lower risk of proximal colon cancer and distal rectal cancer. Although, as we can see here, for individuals who switched to an unhealthy lifestyle, the risk elevation is a little bit higher for distal rectal cancer compared to proximal cancer. This is also expected because a lot of the dietary lifestyle factors tend to be more strongly associated with distal cancer than proximal colon cancer. And when we look at individual lifestyle factors, for smoking, we can see that the majority of the participants are never smokers. So we use the never smoker as a reference group. And for individuals who have smoked or even quit smoking, they all showed some increased risk. And the risk elevation is the strongest for individuals who continue to smoke after screening. And for major chronic diseases, we can see that all the 3 smoking groups showed a higher risk. And the individuals who quit smoking also showed an increased risk although the risk elevation is much smaller compared to the persistent smokers. When we look at the individual dietary and the lifestyle factors, we saw physical activity showed the strongest inverse association with colon cancer. And weight loss also showed a borderline inverse association. And for dietary score, it also showed a borderline significant association. And for the individual dietary factors, we observed that whole grain showed, again, a borderline inverse association. And as you can see, the confidence interval is very wide. This is mainly because individuals did not really change much in their diet and lifestyle. And when we look at the chronic disease, we can see we observe the expected associations, like weight loss, physical activity, higher dietary score, all showed an inverse association with chronic disease development. So some strengths and limitations of the study. The main strength of the study is the large prospective study and with long follow-up time. So this allowed us to assess the long-term risk of colon cancer after screening. And also we have very detailed and repeated risk factor data. This allowed us to assess the change in lifestyle after screening. Some limitations are also worth noting. First, all the data are based on self-reports, and there could be a measurement error. Although in our cohorts, we have done various validation studies and established the validity of the questionnaire in both the screening and the lifestyle assessment. And as an observational study, the residual confounding cannot be excluded, although we have adjusted for a variety of lifestyle factors to minimize the confounding. And finally, our cohort participants are predominantly white and are all health professionals. However, on the other hand, this also helped reduce confounding because the homogeneous study population limited the confounding bias by race, ethnicity, or socioeconomic status. In conclusion, we found that adopting a healthier lifestyle post-colonoscopy screening was associated with a lower risk of CRC and major chronic diseases, while adopting an unhealthy lifestyle was associated with higher risk. For individual lifestyle factors, we found a modest association with smoking and physical activity, demonstrating a statistically significant association. So our study implies that colonoscopy screening may offer a teachable moment for patients to embrace lifestyle modifications for long-term health benefits. And we need further implementation studies to test how to best incorporate lifestyle intervention into the clinic, into the screening setting. And my colleagues in Norway has already started testing this. So we are currently collaborating on a randomized controlled trial of diet lifestyle intervention within the Norwegian screening program. So this is a faith-based program that was initiated in 2022. And we are conducting a randomized controlled trial. As we can see that we enrolled a usual care group. Basically, these are participants that will be just followed observationally. And the control group who will just complete a questionnaire. And for the intervention group, we adopted varying intensity of intervention. So, for example, for the group A, we would give personalized feedback based on the questionnaire information to better guide participants in their lifestyle modification. And for group A, it's every 2 years, and group B is every 6 months. And for group C, we further incorporated virtual counseling to further help patients make healthy lifestyle changes. So the primary outcome of the study is overall adherence to the Norwegian food-based dietary guidelines. So I hope we would be able to share the results in a year or so. With that, I would like to thank all my co-authors for their contribution and also the study participants and the staff for their valuable contributions over the past few decades. I also want to thank our founders and I want to thank you for your attention. With that, I would love to take any questions you may have. Thank you.
Bryce and Katona from Penn. Great work. I know you were looking at the impact on behaviors after screening. Did you have information about what was actually found on the patient screening? Because I'd be interested to know, if somebody had an advanced adenoma, did they clean their act up afterwards, or if they had a clean colonoscopy, did they say maybe eating healthy is overrated and have negative behaviors?
That's a great question. Yeah, we do have very detailed information on the colonoscopy findings. And in the study, we conducted a secondary analysis according to the findings. And we saw that in general, all the groups showed a similar association, but the magnitude was strongest for the high-risk polyps. So that also is not surprising because these high-risk patients may benefit more from their lifestyle modification, or they could have the worst lifestyle to start with. So thank you for the question.
Hey, Vance Albaugh, Louisiana State University. So obviously obesity is a huge driver of cancer in general, as well as colon cancer. Do you know, I know this is older data, but do you know, is body weight or BMI and height included in those data sets, or is it now, and were you able to look at the contribution of obesity to cancer as well?
Yes, thank you for the question. In the lifestyle assessment, we did consider body weight. So as you probably remember from one of the slides, healthy body weight was considered as one of the 5 healthy lifestyle healthy lifestyle conditions. And we showed weight loss showed suggestive inverse association with colon cancer and a pretty strong inverse association with major chronic diseases. Thank you. Yeah.
Finley McRae, I'm just wondering how confident you can be that it's the colonoscopy that's the teaching moment and not something else that represents that time point. So perhaps a nested case control study where you had a control group that didn't have colonoscopy at the same time point might differentiate whether it's the colonoscopy or something else that's working.
Yeah, thank you for the great question. So we actually, in a prior study, we looked at the change in lifestyle and to kind of account for the potential temporal trend of lifestyle, we included the non-screening group as a reference, and we calculated the difference between the two. And we did say there's very minimal change in lifestyle after screening. And I guess in this study, we didn't include the non-screening group mainly because we want to specifically look at how lifestyle changes after screening may influence risk. And we adjusted for the time of the screening to account for any potential temporal trend in lifestyle changes over time. Yeah, thank you for the question.
Xiang Shu from Memorial Sloan Kettering Cancer Center. My question is related to the score change. So I think the baseline score is really matters. So like, have you looked at like for a subject that already have an unhealthy lifestyle, maybe a little change, like improve, will have a large effect compared to those who already have a very healthy, then have you looked at that way?
Yeah, thank you. That's a great question. So we did look at the association according to the baseline, according to the pre-screening lifestyle. And we did say that for individuals who started like with a very unhealthy lifestyle, the improvement is more strongly associated with lower risk of colon cancer. However, this is all quantitative. Like we saw inverse association across different baseline lifestyle score. It's just quantitatively individuals who were worse at baseline showed a stronger association. Thank you.
Thank you, Dr. Song.
Thank you.
Thank you.
After my colonoscopy, I went to an Italian place for a nice meal, but maybe I changed later. So our next speaker, it's my pleasure to invite Dr. Bhumi Madhu as next presenter. She is going to talk about beta-hydroxybutyrate supplementation and Lynch syndrome from an exceptional Lynch research group at UPenn. The senior author is Dr. Mayan Levy.
Thanks for the introduction. I'd like to thank the organizers for giving me the opportunity to share our work here today. I'll be continuing the theme of lifestyle modifications and talking about our findings on using the metabolite beta-hydroxybutyrate as a chemopreventative in Lynch syndrome. So colorectal cancer cases mostly are sporadic, but there is also a majority of these cases that have a hereditary component. The most prevalent predisposing germline condition for hereditary colorectal cancer cases is the Lynch syndrome, which accounts for 3 to 5% of the total colorectal cancer cases. Approximately about 1 in 300 individuals in the United States is positive for Lynch syndrome, and individuals with Lynch syndrome are at a higher risk of developing different types of cancers, including those of the gastrointestinal tract and also the reproductive tract, with up to a 50% risk of developing colorectal cancer. Lynch syndrome results from mutations in DNA mismatch repair pathway genes. Due to a faulty mismatch repair system, mutations acquire over time, which can lead to abnormal growth and cancer development. The currently available management strategies for Lynch syndrome include frequent surveillance and screening for early detection, which is highly recommended in individuals with a family history for Lynch syndrome. There are also other options available, such as surgery, chemotherapy, immunotherapy, and chemoprevention. Chemoprevention remains largely unexplored in the context of Lynch syndrome, and our work is aimed at identifying new chemopreventatives for Lynch. We previously identified that a metabolite called beta-hydroxybutyrate, or BHB for short, can suppress colorectal cancer. In a study that we did a few years ago, we used genetic and choletogenic mouse models of colorectal cancer and supplemented these mice with either the vehicle or BHB. And we saw a pretty dramatic decrease in the number of tumors in mice that were supplemented with BHB, thus highlighting the role of BHB as a tumor suppressor in colorectal cancer. We further identified the underlying mechanism behind this of mainly how ketogenic diet-derived BHB is able to play a tumor suppressive role in colorectal cancer. This mainly works through BHB interacting with the HCAR2 receptor, which is found on the surface of intestinal epithelial cells, and it further induces the downstream transcription factor HOPX, which is then able to inhibit proliferation and tumorigenesis in colon. With these really interesting findings, we were motivated to see whether BHB administration can be used as a chemopreventative strategy in Lynch syndrome. So with this in mind, we wanted to test the role of BHB in Lynch syndrome in two ways. First, we assessed the effects of BHB, of using BHB as an intervention in Lynch syndrome patients as part of a phase 1 clinical trial that was conducted at Penn Medicine. And secondly, we generated organoids from these Lynch syndrome patients and tested the effect of BHB in vitro. For BHB supplementation, we used this commercially available over-the-counter supplement, which is called Ketone IQ. It has an active ingredient of ketone esters called R13-butanediol, which is readily and efficiently converted into BHB. And in our clinical trial, the Lynch syndrome patients received 30 grams of daily BHB supplementation for 4 weeks. So this is the study design of our clinical trial, where we enrolled 20 individuals with Lynch syndrome and screened for inclusion and exclusion criteria and obtained informed consent. These individuals then came in for their visit 1, where we collected blood and rectosigmoid colon biopsies and provided them with the BHB supplement. After that, they started consuming the BHB drink, and they came in 2 weeks into the clinical trial for another blood draw. And at the study endpoint, we collected blood and rectosigmoid colon biopsies to do post-BHB supplementation analysis. All the patients that were enrolled in the study successfully completed it. We also monitored tolerance and compliance in these participants through weekly phone calls, and none of the participants reported any adverse effects. First, to test the safety and tolerability of BHB consumption, we looked at the gross morphology of the colonic biopsies that were collected from these individuals before and after BHB supplementation. Using H&E staining, we scored these samples for crypt damage, epithelial injury, any sort of inflammation or gross abnormalities. And we see that none of these samples showed any signs of damage before or after BHB supplementation, indicating that BHB consumption does not damage the intestine and is safe and tolerable. Next, to look at the effect of BHB on epithelial cell proliferation, we stained the colon biopsies that were collected before and after BHB supplementation for Ki67, which is a marker for cell proliferation. And we see fewer cells in the intestinal epithelial crypt after BHB supplementation that were positive for Ki67. And overall, in most participants, we see that the number of Ki67 cells per crypt was reduced after BHB supplementation. This further highlights that BHB consumption is able to reduce intestinal epithelial cell proliferation in Lynch syndrome patients. Next, we look at the effect of in vitro effects of BHB supplementation using organoids derived from Lynch syndrome patients. We generated organoids from the rectosigmoid colon biopsies that were collected from these patients at baseline, and we treated these organoids in vitro with different concentrations of BHB. And as we can see here in the graph, we saw a dose-dependent reduction in the size of these organoids when they were treated with BHB, further emphasizing how BHB can reduce intestinal epithelial cell proliferation. Lastly, we performed bulk RNA sequencing on the biopsies that were collected from patients at baseline and after BHB supplementation to evaluate if 4 weeks of BHB supplementation was able to induce any transcriptional changes in the colonic mucosa of these patients. We identified over 2,000 differentially expressed genes, and by doing gene ontology analysis, we found genes that were associated with extracellular matrix organization and immune responses to be upregulated after BHB supplementation. On the other side, we saw genes that were associated with metabolic processes to be downregulated after BHB supplementation. But this was encouraging because we were able to see that 4 weeks of BHB supplementation was able to induce transcriptional changes in these patients' colonic mucosa. So in summary, our findings indicate that BHB supplementation with 30 grams of daily oral supplementation for 4 weeks in Lynch syndrome patients is safe and tolerable. It does not cause any damage to the intestine, and it was also able to reduce epithelial cell proliferation. And most importantly, BHB consumption also induced significant transcriptional changes in these patients. Our next steps include assessing the long-term in vivo effects of BHB using mouse models of Lynch syndrome. We also want to further characterize the functionality of these transcriptional changes that are mediated by BHB in the colons of Lynch syndrome patients. And lastly, with these encouraging findings, we want to expand the study to look at the effect of BHB on other hereditary colorectal cancer syndromes. And for this, we have an actively enrolling clinical trial at Penn Medicine to test the effect of BHB as a chemopreventative in familial adenomatous polyposis. With that, I would like to thank everyone who contributed to this study, particularly my mentor, Dr. Bryson Katona, and my former mentor, Dr. Mayan Levy, all the lab members, collaborators, most importantly, the study participants and funding sources. I'll be happy to take any questions. Thank you.
Thank you. This is open for questions now. Please introduce yourself so we can get to know you before you ask your question. But before that, maybe I'll have a clarification. Was this study funded by Ketone IQ in any way, or this was not funded by Ketone IQ?
Not at the time.
Okay. Thank you.
I'm Seema Khurana from Houston, from the Texas Medical Center, University of Houston and Baylor. So I have a question. I'm assuming that your proposal is to put these patients on this supplement long term, right? Mm-hmm. What would happen? Let's suppose they have some infectious or other inflammation because you're reducing proliferation. Would it cause gut injury, or because that could also lead to neoplasia?
Yeah.
Right? Thank you.
That's a great point. Thank you for the question. That would be a concern for sure. So, in the study, we excluded participants with a lot of underlying conditions. So, we haven't directly tested the role of infection or inflammation in this context, but that is something to consider, and we would try to work more on it to identify what's the correlation.
Congratulations on the great study, Ming Yang Song from Harvard. So, do you have the genetic information of the study participants, like their pathogenic variants?
Yes, we do.
I'm asking because, as you probably know, there has been some laboratory studies suggesting that the butyrate on colon cancer can be dependent on the host genetic background. Like butyrate can actually promote cancer development among patients or among individuals with MSH2 mutant types. So I was wondering whether your study participants have any of the MSH2 mutations.
Yeah, thank you for the question. So our study participants included patients who have mutations in all the 4 genes associated with Lynch syndrome. So we had patients with MLH1, MSH2, PMS2, and MSH6 mutations. And the Ki67 data that I showed, and also the organoid data I showed, that was valid in irrespective of the type of mutations associated with the patient. So it recapitulated in all the types.
That's good to know. Thank you.
Sure.
Finley McRae, did you do any serum or blood measurements of butyrate to indicate that you were getting it, to give us some clue as to whether the effect is topical or systemic?
Yes. That's a great question. We did look at that by monitoring the circulating levels of ketone esters, but because the half-life of BHB is so short, not all participants showed an increase just because of the time it took for prepping the patients for colonoscopies, but we do see an increase. And in the mouse models that we are testing, we also see increase in circulating levels of BHB.
And apoptotic markers, did you look at apoptotic
We are
markers?
working on that.
Maybe one last question.
Bill Grady from the Fred Hutchinson Cancer Center. Really nice work. Very exciting to see this. So wondering, have you had a chance to look at the changes on the gut microbiome? And what do you think that might be mediating some of the things that you're seeing in the biopsies?
Thanks for the question. We haven't looked at the gut microbiome changes, but I'm really interested in doing that. So maybe in the future we'll have something, but totally valid. Yeah.
Thank you.
Thank you, Dr. Madhu, for an excellent presentation.
Thank you. Next, we'll have Omar Altani from Allegheny Health Network, who will be presenting GLP-1 receptor agonists are associated with increased risk reduction of colorectal cancer when compared to bariatric surgery in obese patients with diabetes mellitus, a matched cohort study.
Thank you so much for this kind introduction, and thank you everyone for being here. Today, on behalf of my team and I'll be talking to you about our study, studying the difference in risk of colorectal cancer in GLP-1s versus bariatric surgery. So we have no conflicts of interest to declare. So a little bit of background. So why this is important? First of all, colorectal cancer is the second leading cause of death, or cancer-related deaths in the United States, with projections expecting that the incidence of early onset colorectal cancer is expected to double by 2030. Furthermore, patients with type 2 diabetes and obesity have a higher risk of colorectal cancer just due to the association of metabolic risk factors and the incidence of CRC. Now, two interventions that are common in this subgroup are GLP-1s and bariatric surgery. Prior studies has looked at the effect of GLP-1s, comparing them to other anti-diabetic medications, and have so a decreased risk reduction compared to other anti-diabetic medications. However, other studies studying the effects of bariatric surgery showed mixed results, some of them showing decreased risk and others showing increased risk. And to the best of our knowledge, this was the first study to directly compare GLP-1s versus bariatric surgery. So the way we did this is we used Trinetics, which is a retrospective matched, which is a large database containing over 69 healthcare systems in the United States with over 120 million patients. It was a retrospective matched cohort study, and our inclusion criteria included patients with type 2 diabetes and a BMI greater than 30 who had no prior history of colorectal cancer. Following that, we divided our cohort into two groups. First cohort was the GLP-1 cohort, which was identified using RX norm codes. And then patients in that group had to be on GLP-1s for at least 6 months and have it prescribed at least 2 times 6 months apart, and have no history or any ICD code basically for bariatric surgery. Our second group was the bariatric surgery group. We included any type of bariatric surgery using CPT, and they were identified using CPT codes and ICD-10 codes. And we excluded any patients who were taking GLP-1s. And then we only included patients from 2005 to 2019, aligning with the approval of GLP-1s back in 2005. And we identified colorectal cancer by ICD-10 codes C18, 19, 20. We also conducted a secondary analysis looking at obese patients with obesity alone, regardless of their diabetes status. Our outcome was the incident colorectal cancer within 15-year follow-up. We used Kaplan-Meier time to event analysis and calculated hazard ratios. And the analysis itself was conducted on October 2024 on the Trinetics platform. And this kind of explains how we divided the groups. Now, for our propensity score matching, we used multiple variables. We used demographic and lifestyle factors, such as age, gender, race, ethnicity, and exposures to tobacco and alcohol. We adjusted for hypertension and IBD. We also adjusted for medications, such as anti-obesity medications and anti-diabetic medications, and then also personal and family history, and the HbA1c level of those patients. Now, this table shows our baseline characteristics. Initially, the GLP-1 cohort contained around 94,000 patients, and the bariatric surgery cohort contained 25,000 patients, around that. The bariatric group tended to be younger and have more females than the GLP-1 group. And then after one-to-one matching, there was around 21,000 patients left in both groups, with minimal imbalance remaining, mainly in race. Now, going to our results showed that compared to bariatric surgery, GLP-1s had a lower hazard ratio of 0.3. And then upon stratifying that into males and females, it continued to be statistically significant. And when stratifying to age groups, it was statistically significant in the age greater than 45 group, but not in the younger age group of 18 to 45, which was also limited by sample size. And you can see here, the hazard ratio was significant at around 0.3. Similarly, going to our secondary analysis that contained patients with obesity and a BMI greater than 35 alone, our results showed that GLP-1s had a hazard ratio of around 0.39, and it was statistically significant similarly across gender and the age group of greater than 45, but not in the younger age group of 18 to 45. This slide kind of summarizes summarizes our findings, showing the both cohorts that we used. The first cohort was the type 2 diabetes and BMI greater than 30. And the second cohort was the BMI greater than 35, regardless of whether they had diabetes or not. And in both cohorts, when comparing, it was statistically significant at around 0.3 and 0.39, respectively. Now, why that might be the case? So, as you know, hyperinsulinemia, chronic inflammation, and impaired immune surveillance are all key pathways linking obesity, type 2 diabetes, and other metabolic risk factors with colorectal cancer. So, prior work has shown that GLP-1s may reduce colorectal cancer risk by improving insulin resistance and lowering systemic inflammation. Furthermore, interestingly, there are GLP-1 receptors on the endothelial cells of the colonic mucosa. So GLP-1s may inhibit tumor pathways like the Wnt beta-catenin pathway and the PI3K-AKT-mTOR signaling pathway, which ultimately promotes apoptosis and reducing tumor cell proliferation. As I previously mentioned, bariatric surgery's impact in the past has been mixed, with studies showing different risks. Now, going to the clinical implications. So our findings may show that GLP-1s may offer dual benefits for obese patients with type 2 diabetes. Our findings also show that we might need to evaluate therapies beyond glycemic or weight control alone. And then this also supports future prospective studies examining GLP-1s for colorectal cancer risk reduction. However, our study is not without significant limitations. We're using a database that's using a lot of ICD codes to identify our patients and our exposure groups. So first of all, causality cannot be firmly established. Furthermore, there can be potential residual confounding despite our adjustment. And then the Trinetics platforms heavily relying on coding and might contain incomplete lifestyle data may contribute to some of these limitations. And then finally, the Trinetics platform itself lacks information on colorectal cancer screening practices, tumor staging, or molecular subtypes, so we were not able to stratify our outcome of colorectal cancer. And that's everything. Thank you so much, and I'm happy to take any questions.
This abstract's open for questions.
Yeah, Vance Alba, LSU. So I'm an obesity medicine physician, so it's kind of interesting, very interesting data. I think, I guess one of my questions for you is, Ozempic wasn't even approved until 2017, and you only included data up to 2019, which was before any of the weight obesity FDA approval. So I think there's some caution here with that. My question then is, I might have missed it. Did you match for the BMI in each of the groups? For example, is the reason that the risk might be higher in the bariatric group, given that obesity has such an effect on colon cancer, and is that group just inherently higher because the folks who had bariatric surgery had such a high BMI, and the people who were diabetic, it was much lower? I'm just trying to figure out why that is such a difference.
Yeah. That's an excellent question. So first of all, I agree with you that the Ozempic was approved afterwards. So in our study, we did match for body mass index, first of all. So we wanted to take account whether the BMI itself, if it was much higher, it would have affected. We also matched for the HbA1c to see if patients who were severely, had poorly controlled diabetes would be different as well. For the Ozempic itself, we used the 2005 to 2019 without adjusting for each individual medication because it's a limitation of the database itself. Yeah. But I agree with you.
I would encourage you to repeat the study just on a newer data cohort. I think that would be very insightful, but very interesting work. Thank you.
Of course.
Hi, Freak Gilad, University of Chicago. Great talk. I'm interested in whether or not you stratified by the type of bariatric surgery. I know you included all of them, but whether or not there was a difference between sleeve gastrectomy or bypass. And secondly, I know you excluded individuals who had both GLP-1 and bariatric surgery, and I'm wondering if you also looked at the ones that had both of these and whether they had a greater reduction of risk because they had a greater reduction of whatever it is that's causing the colorectal cancer?
Yeah, I think those are excellent points. So unfortunately, we did not stratify further. We just grouped all the bariatric surgeries under one cohort, but I do agree that sub-stratifying those procedures would be very helpful and very insightful, and we would be considering that for the manuscript. And then we also, for the second point, we also we did not. I apologize. Can you repeat?
Whether or not you looked at the group of individuals with both GLP-1 agonists and bariatric surgery.
Yeah. So we did not look at that. We excluded any patients who got both because we wanted to see specifically compare them together. But I do think that this would be an interesting study comparing patients who got both to either one. I do think that would be an interesting study.
Thank you.
Congratulations on the great study. So I'm thinking, have you considered the time course of diabetes? Because we know that diabetes patients in the early years, they have hyperinsulinemia, and then they would develop insulin depletion. And it has been shown that we and others have shown that it is insulin that is really driving the increased risk of colon cancer associated with type 2 diabetes. So I see you have already included metformin in the propensity score. But I was thinking whether you have considered like the time course of diabetes diagnosis. And it's good that you also did analysis among BMI greater than 35. It would be also interesting to exclude patients with diabetes to see if the association still remains. Because I feel like diabetes patients, they have very evolving dynamic in their insulin levels that may complicate the interpretation of the results.
Yeah, I think that's an excellent point. In our study, we did not specify when the GLP-1s or the bariatric surgery was started, just because we wanted to capture a broader range of patients. We did not want to miss any patient and wanted to maintain the large sample size. But I do think it would be very interesting and doable in the Trinetics database, where you can only stratify by the patients who started the medication or the surgery after a certain time course after they were diagnosed with diabetes. So I think this is an interesting topic that we did not address here, but I do think that it's worth exploring.
Thank you.
Of course.
Dr. Dayani, maybe I can ask a question. So your results are really dramatic and provocative. So because you have access to such a big database, could you have included a control group which was neither on GLP-1 or had bariatric surgery? I mean, there's some case reports of bariatric surgery increasing the risk of colorectal cancer because of malabsorption microbiome. Could you, when you rerun the analysis as the audience requested, could you also include a control group? Is that possible?
Yeah, we can use a control group for patients who had like a regular clinic visit for another reason, just an annual checkup, and compare the colorectal cancer risk. That is possible as well using the data.
Because the question is bariatric surgery increasing the risk? Any chance of that, or or is just GLP-1 is decreasing the risk relative to obesity surgery?
Yeah, I agree with you. We wanted to have two comparative groups just to make sure that there was interventions in both groups and there was no bias there. But I agree that a continuation of that sort would be very helpful.
Thank you.
Thank you.
Thank you,
very much.
everyone.
Our next speaker is Dr. Ye Yang from University of Florida Healthcare Center in Gainesville, and he will talk about microbial sulfur metabolism determines dietary taurine impact on gut inflammation and carcinogenesis. And for those of you who have kids in high school, you might better listen up to this presentation.
Thank you for the introduction. I also want to thank the organizer for the opportunity to present our work here. I will not disclose. So our research focuses on the etiology of colorectal cancer, which is among the most common and deadliest cancer types in the United States. The overall incidence and mortality rates of colorectal cancer have plateaued and even slightly dropped over the past few years. One alarming trend is the rise of early onset colorectal cancer, which affects individuals under 50 years old and is often diagnosed at the late stages. So what drives this trend is unclear, but there's emerging evidence that microbiota diet interplay might play a role. The concept of sulfur microbiota diet was devised by Curtis Salthauer and Andrew Chan's group at Harvard. Basically, a score can be calculated by summing the weighted intake of food groups positively or negatively correlated with fecal abundance of sulfur metabolizing bacteria. These bacteria carry genes to produce hydrosulfide. So in essence, a higher sulfur microbiota diet score implies more bacterial sulfide production in the gut. And in large prospective cohort studies, including the health professional follow-up studies and nurses' health studies, to which our previous speaker, Dr. Sun, has given very good introduction to, it was found that the higher sulfur microbiota diet score is associated with increased risk of colorectal cancer. Now, in the nurses' health study 2 cohort, higher sulfur microbiota diet score was significantly associated with the risk of early onset conventional adenoma. 2 bacterial species were found to be positively correlated with the sulfur microbiota diet score. These are Bilophila wadsworthia, which I'll refer to as Bilophila in the remainder of my presentation, and Uracilopicotria bacteria 21.3, which is a largely uncharacterized species. Also, the correlation appeared to be weaker as compared to Bilophila. So what is Bilophila? What do we know about its interaction with dietary sulfur in the context of gut diseases? Multiple studies using geographically and ethnically diverse populations have reported that Bilophila abundance increased in colorectal cancer patient stools and biopsies compared to non-cancer controls. Bilophila isolates were shown to promote inflammation in mice models, although their roles in cancer development have not been demonstrated. Bilophila is best known for its ability to use the sulfur amino acid taurine as energy source to produce hydrosulfide. Diet is a significant source of taurine, and dietary taurine supplementation was found to be protective against colitis and colitis-associated colorectal cancer in mice. In contrast, the metabolite hydrosulfide has long been known to exhibit genotoxic activity at physiological concentrations, and it was expected to contribute to cancer development. So these raise an important question how the bacteria and the taurine interplay might impact gut pathologies. And we hypothesize that by metabolizing taurine to genotoxic hydrogen sulfide, Bilophila determines the impact of taurine on gut inflammation and cancer development. So to test the hypothesis, we use the DSSC-PCMI mouse model. Here, the SPF-EPC mice were pretreated with a broad spectrum of antibiotics to facilitate Bilophila colonization. We used the Bilophila type strain from ATCC that was originally isolated from a perforated appendiceal abscess. Mice also received low-dose DSS to induce self-limiting inflammation and chronic tumorigenesis. So here are the representative pictures of mouse colon at the endpoint, where the polyps were marked out by arrows. So we found Bilophila colonization alone had a very limited effect on colon tumor counts. Taurine reduced tumor counts, but taurine supplementation with the Bilophila colonization led to more tumors. And here are the representative H&E and colon sections with the beta-catenin immunohistochemistry to confirm neoplastic transformation. So this data suggests that Bilophila colonization shifted the effect of diet taurine from tumor preventive to tumorigenic. And because microbiota plays a key role in gut inflammation and cancer development, we analyze the microbiota dynamics using 16S-RR and gene sequencing. Specifically, we collect stools pre-DSS when mice were disease-free, shortly after DSS treatment when mice developed gut inflammation, and at the endpoint when polyps were formed. We found that overall the alpha diversity is comparable between treatment groups, but the Bilophila and taurine co-treatment group show the lowest alpha diversity, especially at the endpoint. Looking at microbiota beta diversity, we found that as disease progressed, there's more separation among the treatment groups. Particularly, you can see the taurine treated mice clustered distantly from the Bilophila taurine co-treated mice across time points. So this suggests the Bilophila and taurine interplay a modulated microbiota along cancer development. Because taurine can be utilized by Bilophila, we specifically look into the impact of taurine on Bilophila colonization levels. So here, each dot represents a single mouse. The shapes of the dot represent different time points. You can see Bilophila was not detected in the control or taurine supplementation groups. While it is detected in the other two groups, the abundance appeared to be higher in the co-treatment group, as shown by the trend lines, and the p-values at the pre-DSS and endpoint. So this suggests that taurine supplementation favored Bilophila colonization. Our next question was what contributed to the tumorigenic effect of the co-treatment? Was it inflammation? To answer the question, we use the DSS colitis model. Here, SPF wild-type mice were treated the same way as AP-semi mice, only that mice were euthanized 2 days after DSS treatment when we expect to see severe inflammation in this model. Inflammation assessment was done by measuring fecal lipocalin-2 levels and histological scoring. So we found taurine significantly attenuated inflammation, confirming previously reported anti-inflammatory effect of the taurine supplementation. Interestingly, Bilophila colonization abrogated the anti-inflammatory effect of taurine, but the co-treatment did not induce excessive inflammation. So we hypothesized that the high tumorigenic effect of the co-treatment was not driven by high inflammation, but by bacterial production of a genotoxic sulfide. And we're currently testing the hypothesis by examining DNA damage response and mutational signatures in the colon of DSS AP-semi mice. So the mouse data has prompted us to wonder how dietary taurine intake might impact the human microbiota function and cancer risk. Depending on the diet, daily taurine intake can range from 9 to 400 milligrams in adult. Interestingly, energy drinks often contain high levels of taurine with up to 2 grams per serving. So energy drink consumption can markedly increase your daily taurine intake. The popularity of energy drink is increasing as shown by the unit sales data in the United States. And it is especially popular among young adults, 20 to 39 years old, as shown by the previous curve here. So this raises an important question, how the trending popularity of energy drink consumption might affect microbiota function and cancer risk in this age group. To address this question, we leveraged a clinical trial performed at the UF Health Cancer Center. In this trial, healthy individuals, 18 to 40 years of age, consumed a high taurine energy drink daily for 5 weeks. And stool samples were collected at baseline at 3 and 5 weeks after daily energy drink consumption. Here's the demographic information. So we also have a control arm where individuals were recruited without energy drink intervention with matching stool samples collected. So we just finished collecting all the samples and we're in the process of doing metagenome sequencing to determine the impact of energy drink consumption on microbiota function capacity. So to give you some flavor of what to expect, here are some preliminary data we obtained from a few subjects after only 3 weeks of dietary intervention. Bilophila abundance measured by qPCR increased in 2 out of 7 individuals in the control arm, but in 5 out of 6 individuals in the energy drink arm. Fecal abundance of TPA, the enzyme responsible for the first step of taurine metabolism by Bilophila, was measured by semi-quantitative PCR, where equal amount of fecal DNA were used as template. You can see TPA was not detected in a couple of subjects, suggesting Bilophila might be absent from these individuals. In those individuals who carry TPA gene, we found that TPA abundance increased in 3 out of 6 individuals in the control arm, but in all 5 subjects we tested in the energy drink arm. So even with this very limited sample size and a short intervention time period, it seems that energy drink consumption elevated fecal levels of Bilophila and taurine metabolism genes. So we expect the more comprehensive metagenome sequencing would provide a clearer picture of the impact of energy drink on microbiota composition and functional capacity. For functional studies, we will perform fecal microbiota transplantation to determine the cytogenic and cancerogenic activity of a pre- and post-energy drink human stools using the DSS AP-semi mouse model. And we also plan to do culturomics to isolate taurine metabolizing, sulfide-producing bacterial strains and test their contribution to cancer development in mouse models. So also to sum up what I show you today, we found that taurine supplementation attenuated inflammation and prevented colitis-associated colorectal cancer development. But the bilophilin conjugation abrogated the anti-inflammatory effect of taurine supplementation and shifted the effect of diet taurine supplementation from tumor primitive to tumorigenic, likely through production of genotoxic hydrogen sulfide. And we also show there's interplay between the bacteria and the taurine, with the taurine supplementation favoring bilophilin conjugation. For acknowledgement, I want to thank all the people who are involved in and contribute to the project, especially my colleagues in the Christian Jobin lab and our bioinformatic support and the clinical trial team and our funding sources. Thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Yang. While we're waiting, very, very interesting work. So it looks like depending on our microbiome, we can ingest certain things versus not others. So do you think you can envision a future where a stool sample will be analyzed, then you can tell me if I should have coffee or supplement drinks? And by the way, how does this drink taste?
Tastes terrible. I personally don't drink energy drink, but I guess in young adults, as shown by the previous curve, it's quite popular. Yeah.
Nikhil Kalon, I'm from Vanderbilt. I am in that young adult category that enjoys my energy drink, so I'm now very scared of what I've done to my own microbiome. So my question to you is, let's say we halt all energy drinks, about how long do you think it'll take for all the washout of the excess taurine in my microbiome to go away?
That's an excellent question. Actually, that's an excellent question. We would like to expand the clinical trial with a washout period to see, once they stop energy drink consumption, how fast the microbiota can return to the original level. But in this trial, we don't have those samples, so but we would like to do that. But based on the data, after 3 weeks consumption, you can see some changes. We would guess that probably need a couple weeks to see some change.
Great talk. Thank you so much.
Very nice talk. I'm Seema Khurana from Texas Medical Center. So my question is, a lot of these energy drinks have very high caffeine levels.
Right.
So if that is true, then even regular coffee should be causing that, right? Is there any, or other drinks, not specifically just energy drinks? You have any thoughts
that's a great
on that?
question. So we focus on the taurine. So our hypothesis is bilophilin metabolizes taurine to produce this genotoxic metabolite, which is sulfide in this case. In terms of caffeine, that's not in our hypothesis, and also actually in energy drink, the most common ingredient include caffeine, taurine, sugar, and vitamins. So there's abundant of evidence showing caffeine can be protective or beneficial in terms of gut inflammation and carcinogenesis. So I think it's safe to drink coffee without taurine added. So yeah.
I think we have time for one more question. So Dr. Yang, really interesting work. So another question, any sex-based differences in how people respond, in mice responded, male, female mice, in terms of supplementation?
Oh, actually our model, the data I show you, we use both female and male mice. So it'd be interesting to test whether there's difference. So from the human cohort studies I show you, the high sulfur marker beta I score is specifically associated with a risk of early onset conventional adenoma in the females. That's a nurses' health study cohort. So we don't know if it's also associated with a risk in early onset adenoma in males. But it'd be an interesting question to tackle. Yeah.
Thank you so much. Wonderful.
Oh, thank you.
All right. Thank you. And our last talk will be links between ursodeoxycholic acid use and cancer risk in primary biliary cholangitis patients, a real-world study. And Dr. Xu from Memorial Sloan will present this for us. Thank you.
Thank you very much for the introduction, and appreciate the opportunity to present our work here today. So I have nothing to disclose. First, the background. So the primary biliary cholangitis is a progressive liver disease where the bile ducts within the liver are slowly damaged and destroyed. This damage is primarily caused by an autoimmune reaction, leads to a buildup of bile in the liver, causing inflammation, scarring, and potentially cirrhosis. The global incidence and prevalence vary widely. For example, the incidence in North America is about 3 times of the incidence in certain Asian countries. Several risk factors have been identified for PBC. For example, the disease is predominantly affecting female. Other risk factors include urinary tract infection, smoking, certain chemical exposures. In addition, studies have identified genetic factors such as human leukocyte antigen locus may play a pivotal role in PBC etiology. So in terms of treatment, ursodeoxycholic acid, UDCA, has been a first line in treatment for PBC for a long time. Although it cannot cure the disease, but it can significantly slow the progression of the disease. Obeticholic acid was recently approved by FDA as additional therapy for patients who do not respond well or cannot tolerate UDCA. In a prior study, we have observed a 20% reduction in 10-year cumulative liver transplant-free survival in UDCA-treated patients compared to those untreated patients. There are several hepatoprotective mechanisms have been proposed for UDCA. The most important one is related to its colorectic effect. Other potential mechanisms include stabilizing the structure of the cell membrane and other properties related to anti-apoptosis, anti-fibrosis, and inflammation and immune modulation. Because of all those mechanisms, so people have hypothesized that taking UDCA could add extra benefits for PBC patients in terms of their risk of developing cancer. It's sort of known that PBC patients have a higher risk of developing cancer. In this systematic review and meta-analysis, you can see PBC patients have 50% higher risk of developing cancer compared to the general population. PBC patients has an extremely high risk of developing liver cancer. There are evidence here and there showing PBC patients may or may not associate with increased risk of colon cancer, lung cancer, or breast cancer. When you look at the UDCA data, the water is muddier, and there are a lot of inconsistent results. The reason for that is summarized here. First, a lot of the prior studies have a small sample size, and as I mentioned, the PBC itself is a risk factor for cancer, so sometimes it's hard to differentiate the effect of the two. So choosing a appropriate comparison group really matters. And so, of course, some study may still suffer from the residual confoundings. So in this study, we trying to partially address those problems. We use a database called Genetics, another genetics study. Thank you for Omar to set up the stage, so I don't have to really talk about this database. I will just skip. So we include about 135 million patients available in the genetics, and we use the ICD codes to define our PBC cohort. And in total, we include about 38,000 patients. We apply some exclusion criteria. For example, if the patient is too young or too old, if they have a prior cancer history or died within the first year of a PBC diagnosis, we exclude them. Then we divide the cohort into two groups. One is UDCA-treated PBC patients. Another one is the patients that didn't receive UDCA. The outcomes of interest include GI cancer, liver cancer, colorectal cancer, and breast cancer. The reason we include breast cancer because the majority of our participants patients are women. We then apply the propensity score matching. This is a statistical method to minimize the confounding effect in the observational study and trying to mimic the randomized control trial. Hopefully it can function like that way, but it cannot never replace the RCT. How does they work? So first, based on the prior knowledge, you need to pre-select a whole bunch of covariates. You think those covariates may affecting the likelihood to for a patient getting a treatment or getting UDCA here. Or you can include some covariates that may affect the likelihood of the outcome. So here we include a lot of covariates. For example, age, sex, race, ethnicity, comorbidities, other medicine use, and surgical procedures, and certain cancer-specific covariates, especially those screening, past screening experience. So based on those covariates, then we calculate the propensity score for each individual involved in the study by ignoring the group label. And then you pick out one patient from each group, then based on their propensity score, and then make a match, a pair. So in this way, you will have a really balanced case control group. So here's the example in our study. Before matching, you can see from this left panel of our plot, you can see the distribution of the propensity score looks quite different. After matching, it looks nearly identical. But pay attention to those numbers here. So that's one of the drawbacks of the matching is like you will lose a lot of sample size. So for results, for GI cancer, in our PS matching subcohort, on an average 3 year of follow-up, you can see UDCA patients have reported less GI cancer compared to the non-UDCA group, and this difference is statistically significant by log-rank test in this Kaplan-Meier curve plot. Remember, I said that the sample size has been reduced a lot because of the matching. So we went back to the entire cohort and see if we include everyone and adjust as many covariates as possible in our Cox regression analysis. What will the results look like? So here in this analysis, we have shown including everyone also. Has showed significant inverse association between the UDCA use and GI cancer risk. Then we look at the results, whether trying to figure out whether those results is mainly driven by liver cancer. And you can see in our PS matching analysis and both the Cox regression, both analyses have shown very significant inverse association between UDCA use and the liver cancer risk. How about colorectal cancer? Unfortunately, we didn't find any significant association between UDCA use and colorectal cancer in either PS matching analysis or the Cox regression. You may notice that the number of the patients with the colorectal cancer is really small. You may probably argue that the insignificant association may be due to insufficient power here. Finally, for the breast cancer, in our Cox regression without a PS matching, you can see there is a strong inverse association between UDCA use and the breast cancer risk. However, when we look at the PS matching analysis, this significance is gone. But if you look at the point estimation here and the 95% CI here, it's just barely over the 1. So you can probably still suggest that there could be a suggestive inverse association between UDCA and the breast cancer risk. So in this study, we have included over 20,000 PBC patients, which is a relatively large study. We also have access to high-quality real-world data. And we apply the propensity score matching to help address the confounding issue, and which can largely increase the comparability between the two groups. We also apply the time to event analysis, trying to infer the association temporality. You may also argue that using the EHR data, so the analysis could be less prone to the self-reported errors or recall bias. Our study also have several limitations. By nature, it's still retrospective data analysis, and we have relatively short follow-up time and a small number of cancer outcomes. We cannot completely rule out the residual confounding, such especially from lifestyle and the diet factors. Furthermore, we only include the baseline UDCA yes/no use in our analysis. We didn't consider the duration, compliance, or response data. Finally, we lack the data to figure out why some of the PBC patients were not prescribed to the UDCA, given it's the first line treatment. So in summary, this is a large real-world study where we found some benefits for taking UDCA on GI cancer risk, especially for liver cancer risk on PBC patients. We also identify a suggestive inverse association between UDCA use and breast cancer risk. Of course, all those are very preliminary. We really require additional efforts to validate those results. So with that, I would like to thank you for your attention, and I'm open to any question you may have.
Thank you. Nice talk. I know you don't know the underlying reason why UDCA is driving these responses, but that being said, I know that in NASH/MASH, fibrosis is one of the reasons that you can get cancer. So do you know whether or not in your UDCA group versus not UDCA group, whether the fibrosis was similar between those two cohorts going in, and maybe that's one of the potential reasons that could be why you have a difference in those groups?
Yes. We do look into that, and we match that exactly 1:1. So I don't think that's a confounding issue in our study. Thank you very much for your question.
So, great presentation. I had a question. So PBC can drive the risk of colorectal cancer through causing ulcerative colitis. So were you able to, I know your numbers were small for colorectal cancers, but were you able to look at the subgroup which has both PBC and UC to see if UDCA was protective?
For colorectal cancer?
Yeah.
Yeah, I really wish I can have a larger data set to answer that question. Yeah, because the cases in our data set is really small for colorectal cancer. It's only 30, 40. So I don't think we can do that in this data set.
Another question I had was, what was the hypothesis to look at breast cancer? What was the reason you wanted to look at the role of UDCA in breast cancer prevention?
Yes, there is no direct evidence, but there are some hypotheses the UDCA could change the microbiome, and then some also subsequently change the lipid metabolism and estrogen metabolism. That could be one of the hypotheses. Yeah.
Perfect. So that brings us to the end of this session. Thank you everyone for your attention. We gave you extra 7 minutes to hang out with friends and for an extra good meal. And feel free to ask the speakers any questions you might have. And thank you so much for your attention.